Primary hyperparathyroidism is a biochemical diagnosis. Whilst the condition may be managed conservatively, where clinically indicated, parathyroidectomy offers potential cure. Parathyroid localisation imaging can neither confirm nor exclude a diagnosis of primary hyperparathyroidism, but may guide surgical planning. Therefore, localisation imaging studies should only be requested in patients with an established biochemical diagnosis or suitable and willing surgical candidates where focused parathyroidectomy is contemplated. However, negative localisation imaging does not preclude bilateral exploration. Under the principles of choosing wisely, we set out to determine if parathyroid localisation imaging studies were being optimally utilised, that is, for surgical planning in patients with biochemically established primary hyperparathyroidism in our tertiary hospital. In discussing findings, we hope to foster a culture of requesting imaging for optimum utility within our institution and other healthcare settings. We conducted a retrospective audit of all parathyroid localisation imaging reports performed over a one-year period in patients with possible hyperparathyroidism but without end-stage renal failure, and we reviewed additional clinical and biochemical data from electronic sources. Within the audit period, 45 patients underwent a total of 58 localisation imaging studies. 38 patients had an established biochemical diagnosis of primary hyperparathyroidism, of whom 4 had recurrent or persistent disease despite having had previous parathyroid surgery. In 7 patients, the biochemistry was not confirmatory. When considering the number of localisation studies rather than the number of patients, the distribution between those with and without an established biochemical diagnosis was similar. 29 patients, being 64% of the total, proceeded to surgery. Likewise, a similar proportion of localisation studies were requested for patients who subsequently underwent surgery. Localisation studies in patients who did not have an established diagnosis of primary hyperparathyroidism or who did not undergo surgery despite an established diagnosis could be considered low-value investigations. Excluding the patients with recurrent or persistent disease where bilateral neck exploration might not be feasible, there were 18 such potential low-value studies comprising 31% of the total number of localisation studies performed. Of parathyroid localisation modalities, sestamibi SPECT-CT and neck ultrasound were the most frequently performed, with almost all studies requested by endocrinology and endocrine surgery. In conclusion, at our tertiary institution, most parathyroid localisation imaging studies were performed in patients with biochemically established primary hyperparathyroidism who proceeded to surgery. However, a significant proportion were undertaken without indication or utility. Confirming a biochemical diagnosis and the patient's suitability and willingness for surgery prior to arranging localisation studies could decrease the number of low-value investigations being undertaken. These choosing wisely principles have been presented at our hospital, and the message is relevant to other tertiary and non-tertiary healthcare settings. Thank you.